So I'm going to talk to you about pediatric cervical lymphadenopathy and what you need to know in 6 minutes. How many of you guys have kids in your practice? And how many get these referrals? Yeah, so it's a fairly common referral that I get, and I think it can be hard. These parents are pretty amped up, especially if they have consulted Dr. Google and read all the scary things that this could be. So it's a challenge to really calm them down and reassure. So really what I hope after these 6 minutes that you will take away is that there are features on history, physical exam, and ultrasound that help us to identify those patients that we should have a higher index of suspicion and may want to intervene further. So how common is palpable cervical lymphadenopathy? It's actually extremely common, especially in young children. So the first thing I usually do is explain this to parents, that just because you can feel a lymph node doesn't mean it's pathologic. In fact, we all have lymph nodes in our neck, and in fact that's proof that the immune system is working, and it's actually a good thing. So I think that's an important thing to let parents know, because they're not always clear on this. They feel that if they can feel it, it must be abnormal. Generally, the most common reason for palpable lymphadenopathy in children is going to be infectious, and often the pediatricians will have already done sort of a cursory immune workup or gotten labs and even put them on a course of antibiotics before they get to us. And it's when the lymph node is still persistent that usually they get referred. So what do we do with these kids? And in fact, if you look at the literature, there really isn't a lot of great studies out there to help guide us. And in fact, the best one that I found is actually from 2015. It's the Italians. They basically got their pediatricians, their infectious disease docs, and their otolaryngologists together, and they came up with an algorithm. And in the interest of time, I didn't put the algorithm in here. It is in the paper, though. It's relatively complex, but I think they had the general idea was a good one, which is they broke up patients into those with small lymph nodes and those with large lymph nodes, and then within that group, those with obvious infectious etiology and those with no obvious etiology. And so it's really the kids with larger lymph nodes with no obvious infectious etiology that we're worried about, and really the majority of them are in that other category of smaller lymph nodes with no obvious infectious etiology. And so what do we do with them? And they did come up with this list of red flags. So certainly most lymph nodes are sort of soft and squishy and they move around. So if you've got a hard, firm one that isn't very mobile, your level of suspicion should be raised. Size is certainly also an issue. And then supraclavicular is considered more concerning than jugulo-digastric or the posterior triangle location. And finally, whether there are associated B symptoms. But I will say, I think really the minority of kids ever have any of these symptoms, at least in my clinic. So what do we not want to miss? Well, non-Hodgkin's lymphoma is the third most common childhood malignancy, right behind leukemia and brain tumors. It's the most common pediatric malignancy of the head and neck. The second decade is the most common age of presentation, and really the most important thing is it has a very good 5-year survival. So we want to identify these kids early and get them into treatment if we can. How many of you guys have ultrasounds in your office? Yeah, so I think this is a wonderful condition to use ultrasound, whether you have it in your office or you have radiologists do the ultrasound. I took the ultrasound course and was all gung-ho to be doing this on everybody. And once you see how much you actually need to do to bill and interpret, I don't actually do that because I don't have time. But I do use it as an extension of the physical exam, and I think it can be extremely helpful to show parents in real time what you're looking at. You can get a more objective assessment of the size and then follow that over time. And also just the nodal architecture. It's also can give you a great sense of that. And so there on the left you can see a nice normal lymph node, kidney bean shaped, homogeneous echogenicity, and a central hilum. And then if it's rounded, you start to get a little more concerned. If there's increased heterogeneity or chaotic vascularization, those are also findings that make you a little more concerned. The problem is, what do you do next? Well, FNA really is not a good test in this situation. And part of that is there's a lot of non-diagnostic tests as well as false negatives, because you can imagine there's a sampling area. You're trying to put a needle in something that's bigger, and so it's only really helpful if you get an abnormal result. So really, the gold standard is excisional biopsy, but there are small but present risks of that, both from general anesthesia standpoint in terms of development in the young brain, as well as small surgical complications. So we went ahead, one of our fabulous residents, Kathy Way, did this study where we looked at all our kids over the past 10 years that were referred to our office, and we eliminated those that had obvious infectious or malignancy etiology. So we had 110 patients. Ultimately, 19 of those underwent surgical excision. And some of the reasons we did that was parental anxiety, and I think that's also a valid reason to consider it. Sometimes they just, they can't take the not knowing. So there were 4 patients that got their biopsy mainly for that reason. And really the take-home point is that 0 out of 19 had malignant pathology, so none of them. So really the point is the majority of pediatric cervical lymphadenopathy is benign. There are some things on history, physical exam, and ultrasound that may help you determine who needs intervention, and FNA really has a limited role. But in my practice, the most common thing I'll do is just bring them back, repeat ultrasound serially to measure size and nodal architecture. Thank you.